last talk about the place of aqueous humor analysis in uveitis. The presenter is Lilian Julian. She's a consultant ophthalmologist, Cleveland Clinic, Abu Dhabi. Lilian.
Good morning. Thank you so much for this invitation. If I show you here, this fundus, most probably you will say this is a case of toxoplasmic retinochoroiditis, and most probably you are going to be right with your diagnosis, but sometimes clinical diagnosis is not so straightforward, as you can see in this second picture. Same here, these are granulomatous creative precipitates, as well as these are, and as well as these are. But the three are different clinical cases, and it's not so easy to make the diagnosis only with the clinical picture. I can show you here a diffuse stromal iris atrophy, and this is most probably related to herpes infection, but again, we are not 100% sure which subtypes of herpes virus is responsible for this clinical picture. So sometimes you need to move from a clinical diagnosis to a molecular one, and that is the place of intraocular fluid analysis in uveitis. First of all, what to sample? You have to keep in mind that most diagnostic examinations for aqueous humor samples are similar to those performed in vitreous samples. So how to take the decision about what to sample? Aqueous humor is easy available. The technique is pretty easy also, but the volume you are going to obtain, it is small. You also need a sophisticated laboratory to process and handle this sample, and sampling the aqueous humor will not affect the visual acuity of the patient. In most cases of uveitis, aqueous humor will be your first choice because of its easy availability. Nevertheless, in endophthalmitis cases, we still sample the vitreous. And for malignancies, you have to keep in mind that definitive diagnosis is the vitreous biopsy. Nevertheless, as we are going to see later, aqueous humor analysis is also very useful in malignancies. Then how to obtain your sample? Well, this is the way I do. It's an aseptic technique under surgical microscope and with a tuberculin syringe. There is an aqueous pipette. I don't use that device, and some colleagues also, they perform the sampling at the slit lamp. You can obtain 100 to 200 microlights in 1 or 2 attempts. The technique is very safe. The only important risk is the effraction of the lens anterior capsule, so it's better not to perform this if you can under pupil dilation. Try to avoid to do this under pupil dilation. Then, once you have obtained your aqueous humor, what to do with it? You have 3 different pathways. One is cytological examination, the next one is microbiological examination, and the last one is cytokines analysis. Cytological examination is mainly used for the diagnosis of intraocular malignancies. You have to keep in mind that you need a very quick transfer of your sample to the laboratory, and you are going to perform in your sample cytology or flow cytometry. Microbiological examination of aqueous humor is by far the most well-known technique. We use mainly PCR, which is more sensitive and faster than culture. It can be made qualitative or quantitative, and with PCR we can detect the DNA of viruses, bacteria, and parasites. We can also perform intraocular antibody production in aqueous humor through the Goldman-Whitman coefficient. Finally, cytokines analysis are mainly used for research purposes. Nevertheless, IL-10 levels in aqueous humor is clinically very important for early detection of primary intraocular lymphoma. PCR, as I have said before, is the most common procedure we apply to aqueous humor analysis. You have to keep in mind that positive results of PCR are directly related to the pathogenic load in the aqueous humor. It is a highly valuable tool for the detection of viruses, but in bacterial and parasitic infections, less DNA is available, so that negative results of PCR do not implicitly exclude involvement of a particular pathogen. Highly sensitive PCR might also lead to clinically false positive results. That's why Goldman-Whitmer coefficient and PCR are used complementary. You have to remember to always correlate your results with the clinical picture you are facing and with the immunological status of the patient. The Goldman-Whitmer coefficient is the ratio between the specific immunoglobulin in the aqueous humor versus the total immunoglobulin in the aqueous humor, and this is correlated to the same ratio in the serum. Whenever a result is more than 3, it is considered that the antibodies are produced in the anterior chamber. This is an important tool to correct for the leakage from peripheral blood. It is possible to obtain false positive results in cases of polyclonal activation and false negative results in some cases of toxoplasmosis. Again, that's why Goldman-Whitmer coefficient is a complement of PCR in those infections with low pathogenic loads. Then, for different pathogens, we have a preferred method to analyze our sample and also a preferred site for sampling. As you can see here, in most cases, Goldman-Whitmer coefficient and PCR are used, and in most cases, also aqueous or vitreous are equal. But you have to remember some important exceptions. One is fungal infection. For fungi, the preferred method is still the culture, and you are going to sample the site of inflammation, which mostly is the vitreous. The other important exception is, again, bacterial endophthalmitis, where the vitreous is the preferred site for sampling, and the culture and PCR are almost equal. For toxocariosis, remember you are going to go for intraocular production of antibodies, not PCR, and this is done with the Goldman-Whitmer coefficient. In atypical cases of ocular toxoplasmosis, whenever you are not able to make your diagnosis only by clinical examination, you have to keep in mind also the immune status of the patient. If you have, for example, large lesions in an immunosuppressed host, PCR will be much more informative than the Goldman-Whitmer coefficient. And the opposite is the case for small lesions affecting the immunocompetent host. In this case, you are going to search for intraocular antibodies. Flow cytometry is very useful in the diagnosis of intraocular lymphoma, and again remember that the gold standard for the diagnosis remains the vitreous biopsy. Nevertheless, this is very fast, and it can give you an idea about how to proceed or not with a vitreous biopsy. I remember you that with flow cytometry you look for monoclonality of the cells. Then, is there any place, I think this is the next one. This is relatively new. This is the use of aqueous humor biopsy in the diagnosis of retinoblastoma. The aqueous humor might be a surrogate for tumor biopsy, and even though this is new, I think this will probably change the management of retinoblastoma in the near future. Then regarding autoimmune uveitis, Is there any place of aqueous humor biopsy in autoimmune uveitis? Well, till now, the analysis of the cytokine networks was used to elucidate the pathogenesis and develop new treatment strategies. Nevertheless, as you can see in this paper, there is a possible role of infectious triggers in classic autoimmune uveitis. This paper is particularly talking about intraocular production of antiparvovirus antibodies in ocular fluid of patients with juvenile idiopathic arthritis associated uveitis. And I have to go back because I think we missed two important slides. This is one. There is absolutely a place of aqueous humor analysis in the diagnosis of tubercular uveitis. The diagnosis of tubercular uveitis is very difficult, and most of our cases are labeled as presumed tubercular uveitis. There is more and more experience with aqueous humor analysis in getting the correct diagnosis, so most probably in the future we are going to use this as a routine to get the diagnosis in our patients. This is another important case in the management of intraocular lymphoma. Even though the gold standard remains the vitreous biopsy, interleukin-10 measurements in aqueous humor are very useful for screening patients with suspicion of primary intraocular lymphoma and also for evaluating the response to treatment. So finally, these are your take-home pearls. Serology is not informative in case of infectious uveitis. If you are in doubt, you have to perform ocular fluid analysis. Before a vitreous biopsy, you should consider aqueous humor analysis. Whenever is possible, in cases of infectious uveitis, you have to perform both PCR and Goldman-Whitman coefficient together. And if you suspect ocular malignancies, aqueous humor biopsies can provide very useful information. Thank you very much.